uh, um, mainly laxatives.
What's their dosage form? Is it a solid or a liquid?
They
Liquid.
can be either. They can be. Are they exclusively liquid? I don't think so because okay, I'm not very sure, but I think they can be enemas can be liquid or like the suppositories. I'm not sure, but I know they're laxatives.
It's just liquids. Edible
Okay.
liquids, while suppositories are the solid dosage form.
Ah, okay.
Okay, then pessaries. Hmm? Pessaries are for which roots? Okay. Pessaries for vaginal, then pastilles. Okay, pastilles.
I
Okay,
think
none of
pastille is like lozenge.
lozenges. Okay. So we good. Is there anyone with maybe, I don't know, either a dosage form or a route that maybe they need us to talk about? You can just unmute, ask, add, or add to the chat. Then moving on, the process in which an oil in water emulsion changes into a water in oil emulsion is called what? Okay, I'm seeing Sophia says phase inversion. Okay, then Pablo has also added on that question about the dosage forms. Enemas can be liquids or gases. Okay, so I think we've talked a lot about emulsions. If there's no question or addition, then I guess we can continue. Then all of the following are correct concerning enteric coated tablets, except. So which one of these options is not true about enteric coated tablets? Okay, Rami says C, they are formulated to release the drug slowly. That's for which dosage form, Rami? Okay, extended release. Yeah, extended release, sustained delays, delayed release. Okay. Okay. Okay, someone asked if there is a difference between sustained release and extended release. Honestly, I didn't think there is a difference, but maybe someone can help us with that. What's the difference between sustained release and extended release? Okay, and also, so sustained release, modified release, controlled release. What's the difference between all those, if there's any?
Sustained release and extended release mean the same thing.
And what was the other one? Modified release was
Okay, from what I understand, not delayed, modified release is just a way of trying to describe maybe sustained release and delayed release. So sustained release or extended release, these are formulations. Sustained release, formulations designed to release the API over a period of time. And the benefit of that is reduction in the dosing frequency and stability in plasma concentrations of the drug. When I talk about delayed release, is a release, say a drug is supposed to be released in the intestines, but it has to go through the stomach. So if we can delay the release so that it gets to the point where it's supposed to get to, then we call that delayed, in simpler terms, I think.
yeah. So then that would mean either both enteric coated tablets, delayed, sustained, they are all forms of modified release tablets.
Yes.
Then okay, anything else? Let's see what we have in the chat. Okay, modified release is a general form. Okay. Then, okay, moving forward, dash causes disintegration of effervescent. Yes?
For the previous question, enteric coated tablets are, I didn't see the word except. Thank you.
Okay. Okay, then still on that previous question, what are polymers used to make the extended and sustained release tablets? So if someone finds the polymers used for the sustained or slow release, then you'll just share it in the group. Then we'll look at it later. For now, we can continue. So what causes disintegration of effervescent tablets? Okay, we're being told carbon dioxide. And then the simplest and most commonly used method of particle size analysis for powder is which one? Okay, we use sieves for particle size analysis. Anything we need to discuss there, my guys?
What is elution and like where do you use the Andreessen pipette?
So method for elution is the process of separating particles based on their size, shape, and density, using a stream of gas or liquid flowing in a direction usually opposite to the direction of the sediment. Okay, so for used to separate particles. So it's like you have a, what do we call it? That elution tag from the image I'm seeing here. It looks like a funnel thingy, but then at the almost at the base is where your fluid flows in, then your particles are can you send an image of what I'm saying? And that one is it's mostly used to determine particle size distribution. And then the Anderson pipette, it's just a micro pipette. It's a small pipette that is used to extract very precise amounts of whatever you're using.
For C,
Uh-huh.
for C, it's
Mhm.
just a method that is used to determine sedimentation. Like it's used for to see sedimentation rate or yeah.
Okay, I see this in Yashoda's thing, and it's saying that it's used to measure sedimentation volume, specifically the volume.
Okay, so I'm saying a question here. If we need to know the sieve numbers and sizes, I personally don't know their sizes, but I think for their inverse, yeah, the small sieve size numbers are for big particles and vice versa. That's what I think, but personally, I don't know the sizes and I have no intentions. Someone tell us about the sieve sizes and the numbers. Is it something we need to know?
For now, maybe if you know, you can just share. you'll remember it if it's shared right now.
Yeah, you can just share. And then for these things, it's much better, or I don't know if it's easier if we share them in the group so that we can also keep them for next time instead of just sharing them in the chat box. Yeah, but what I know is that the sieve numbers, small sieve numbers are for big particles. Then the bigger sieve numbers for smaller particles. Then which of the following neurotransmitters has an excitatory effect in peripheral synapses? Yep, so moving forward, which of the following neurotransmitters has an excitatory effect in peripheral synapses? Okay, I'm seeing in the chat box there's Divya has shared for the previous questions about the sizes, the sieve size, and and the particle. That also share it in the group, Divya, kindly. And then for the current question, Okay. And then, so neurotransmitter with an accessory effect in the peripheral synapse. I can see there's a song going on there called epinephrine. Then also an image has been shared on the group on those neurotransmitters, which are excitatory and inhibitory. So maybe you can also have a look at that. Then I think we can move on, unless there is something we need to note. Okay, so which of the following antihypertensives act by dilating arterioles, but not the veins? Okay, I'm saying in the chat box, Dr. says hydralazine. And what about minoxidil? How does minoxidil act, guys?
Minoxidil si ile ya nywele.
Neo, but it also has, I think it also has antihypertensive properties, which I'm trying, now that's what I'm asking. How does it act for her?
Oh, okay. Just Google that.
Okay, I'm
It
seeing,
relaxes blood vessels so that blood passes through them more easily. So it helps lower blood pressure.
yeah, so it's specific for arterial vasodilation.
Yeah, the direct vasodilator. Mtu ametuma kwa chat explanation better.
Okay, okay. Someone had also suggested maybe they can also at least explain to us why they thought it's A. Or someone, if there's a reason and you other than knowing minoxidil only dilates the arterioles, maybe you can say why you don't think it's hydralazine. Okay. Someone here says even A is specific for arterioles. Okay. So yeah. So we are saying so both minoxidil and hydralazine are specific for arterioles. Okay. Shina says we can just move with hydralazine. Guys, what do you think we should go with? Okay, we move with both. If you find yourself in the mix, you'll just figure out what. Okay. So I think we can move.
Hi. From our lecturer's notes, minoxidil has both venodilation and arterial, but the arterial is more predominant. More predominant.
So it has both, just that arterial is more predominant. So we go with hydralazine.
Yeah.
Okay, thank you for that. Okay, now moving forward, hemophilia B is a coagulation disorder that arises due to deficiency of which of the following factors? Okay, I'm seeing our factor 9, hemophilia B. I think we have seen hemophilia, I don't know how many times, but yeah. So if you, okay, everyone says hemophilia B is factor 9 deficiency. I don't know if there's anything more we need to say about that, but if there is, tafadhali just unmute or send it in the chat box, ama kwa group. Okay, I'm seeing Dr. says it's also known as Christmas factor. Hemophilia A is factor 8 deficiency. Then moving forward, the following are advantages of liposomal amphotericin B over the conventional amphotericin B, except which one? Mm.
Ilikuwa ilikuwa chafu.
Yeah, I'm saying, okay, okay, B, lower doses. Mhm. Honestly, I don't know what to say about that. So maybe you can just, yeah, even Shrina is saying maybe we can discuss on it. Yeah. Gaius, Divya, bring us up to speed on liposomal amphotericin B and conventional one. So I'm saying, Divya says liposomal amphotericin B has a broad spectrum of activity with a low risk of the resistance and displays fungicidal activity. It's a safer alternative compared to the conventional one. Mhm.
Okay, on the fact that it reduces nephrotoxicity, amphotericin B is usually, it has also constrictive effect on the afferent arterioles in the renal tubule. So that usually leads to nephrotoxicity. So when you do the liposomal amphotericin B, it usually has a higher molecular weight than the normal amphotericin B. So it won't be able to go through the glomerular filtration to affect the nephrons. So it reduces, now that will be reduced, what is it called? Like it won't be nephrotoxic to the kidney, sorry. And also it's it becomes more lipophilic, so it can't be excreted easily. I don't know if that.
Okay. Yeah, I'm also seeing Divya has also added something on the chat. Okay, anyone else with something to add? Felicia, you want to?
Yeah, can we also discuss on it how it is used to treat cryptococcal meningitis?
Can we discuss? Okay, I've not heard.
Let me type it out.
I think as she types that out, maybe we can continue, then we'll come back to it. Question 183. All of the following methods are used to remove unabsorbed poisons in management of poisoning, except which one?
I think I heard her say, ask if we can discuss how amphotericin B is used in cryptococcal meningitis.
Very good. Guys, I think you had the question. Now we can maybe answer that before we move on.
Perhaps I can say the little I know. For that, for cryptococcal meningitis, we have the 3 phases of treatment. So, okay, first of all, cryptococcal meningitis, mostly it will occur in the immunocompromised patients. Hence the 3 phases of treatment. There's the induction phase, which will last 2 weeks, the consolidation phase, which will last 8 weeks, and then the maintenance phase, which will continue until the CD4 count is sufficiently above a certain level. So the 2 weeks, for the first 2 weeks, induction, you'll just give ampho-B plus flucytosine. However, in Kenya or generally even in other countries, getting flucytosine is quite hard and it's very expensive. So they just give ampho-B plus fluconazole. Then for the consolidation phase, they will give just fluconazole for 8 weeks. Then for the maintenance phase, they will again give fluconazole indefinitely. So for the induction phase, fluconazole will be given at a dose of 800 mg OD. For the consolidation, 400 mg OD. For the maintenance, 150 to 200 mg daily. Yeah.
Thank you for that, Daktari. Now we can go to question 183. Wait, Gaius, Stanley is asking that you kindly you say about induction again.
So for induction, it's 2 weeks, and you'll give ampho-B plus flucytosine. Or in the case that there is no flucytosine, you can give ampho-B plus high dose fluconazole. That is usually 800 mg. Yeah, some guidelines say 1600 mg, but in Kenya I know they use 800 mg.
Okay. Sawa. I'm also saying, as we finalize on question 182, someone has also sent the doses for liposomal amphotericin B and the conventional one. So from that, actually, the liposomal amphotericin B has higher doses, 3 to 4 milligrams per kg compared to 0.7 milligrams per kg. Okay, then that's okay. And then moving on, all the following methods are used to remove unabsorbed poison in management of poisoning, except which one? Okay, I'm seeing we're being told diuresis is not used to remove unabsorbed. Okay. Anything we need to discuss there, guys? Kindly niambie if we need to talk about anything. Charlene is asking about the management of poisoning. I think there's something that was sent in the group. I don't know. Stanley, maybe you can send it if you have it. Karibu, maybe you can send it again so that we can find it easily on the different poisons, their antidotes, and everything. Okay. It's been sent in the so Divya has sent something in the group on the different poisons and their antidotes. Yeah, management of all that. Okay. And then the next question, all of the following symptoms are associated with organophosphate poisoning, except which one?
I have a request.
Okay, Lydia.
Can we do organophosphate poisoning as someone has requested before, and then before we go on with answering question 184? Because organophosphate poisoning is one of the most commonly poisoning that occurs.
So Lydia requests that before we even settle on a choice, we first talk about organophosphate poisoning. Will someone give us a crash course on organophosphate poisoning? Someone tell us about the, what is it called? The MOA of organophosphates. How do they cause poisoning? Okay, we're being told they irreversibly binds to acetylcholinesterase and they prevent the breakdown of acetylcholine. Okay, so then what kind of symptoms are we expecting from that? Okay, I'm saying there's quite a bit of discussion in the chat box. Okay, for the antidote, you can give atropine or pralidoxime. Okay, then also there are a few things that have been sent on the group. Then there's also that mnemonic for you to at least be able to remember the muscarinic features. Yeah, so okay. I don't know what else we need to say about organophosphate poisoning. Lydia, something we've forgotten? Patients tell us about aging of that poison and everything and how it, I don't know, something about aging, how the poison ages or something. Okay. Oh, okay, yeah. Pralidoxime can't work after aging. So for the antidotes, we'd say to use atropine or pralidoxime. Pralidoxime mainly, from what I'm seeing here in the chat box, what typing so fast I can't keep up. Okay, Abdul Malik, kindly tell us about why we can't use pralidoxim after aging.
Okay, I think from what I remember vaguely is that aging is when now the enzyme is permanently phosphorylated by the organophosphate, and that now pyridoxine cannot dissociate the organophosphate from the enzyme. Yeah. So that's it. I don't know if it's clear.
Kindly repeat.
Okay, it's when the acetylcholinesterase enzyme has been now permanently phosphorylated by the organophosphate, and now pyridoxine cannot dissociate it from the enzyme. Yeah.
Okay, so from what I have understood, basically, initially, the binding of organophosphates to acetylcholinesterase is it's reversible. But then with time, you get changes like occur, like let's call them conformational changes occur to that complex, and the binding becomes irreversible. So then pralidoxim is unable to reverse that. But maybe you can tell me if I have understood that correctly. Okay, you've been told that after phosphorylation, there will be a loss of organophosphate group, making the bond between the poison and acetylcholinesterase irreversible, that pralidoxim cannot reactivate the acetylcholine. I don't know if we are all together there, or maybe someone needs some clarification before we move. Okay, I assume silence means you're all satisfied with the discussion. Then we can now, based on what we have discussed now, so which of this is not associated with organophosphate poisoning? Jamani, yet after your discussion yote. Sunshine says D. And Betty seconds the answer. So we constipation. Yeah, some activities, good. So constipation. Okay, then I think we can move to the next question. Which of the following is contraindicated in renal failure? Which of the following is contraindicated in renal failure? Okay, I'm saying you guys are saying spironolactone. Kindly Enlighten us why is spironolactone contraindicated in renal failure? Sunshine, Rami. Why is spironolactone contraindicated in renal failure? Or
Risk
any
of hyperkalemia. Because it's potassium sparing.
Okay, it's a potassium sparing, and renal failure is also associated with hyperkalemia. Okay.
I think you should note other drugs that are contraindicated in heart failure.
In heart failure, kidney
Yes.
failure. Oh, what?
Oh, yes, in renal failure, sorry. In renal failure, other drugs that are contraindicated in renal failure.
We have the NSAIDs, SCI inhibitor, and angiotensin receptor blockers.
Okay. So in the chat box, let me see. Oh, okay. So guys, you're asking, so in a situation where we can monitor for potassium sparing, in a situation where we can monitor the potassium, then would that mean that spironolactone will not be contraindicated if we can monitor potassium levels? Is that what you're asking, Gaius? Okay, so okay, so is it that spironolactone is contraindicated? Is it because we can't monitor, or it's because they actually have the same side effect, so they end up increasing the risk of that? Personally, I think they would still be contraindicated, but I don't know. Someone kindly answer what Gas is asking, that if we are able to monitor the potassium levels, would spironolactone still be contraindicated?
There's still an
For me,
issue with folic acidosis when you use spironolactone, so you cannot use it.
for me, I think also we will still contraindicate it because if we can describe potassium ion in terms of TDM, it has a low therapeutic index. So in such a case, you can't risk because patient will suffer from serious arrhythmias.
Okay, guys. Things otherwise, he says that actually spironolactone retards CKD progression to end-stage renal disease. So if hyperkalemia is the issue, but we can be able to monitor the potassium levels effectively, would spironolactone be a good drug to prevent progression of CKD? Gaius, are you in a position to unmute? Maybe if we can just discuss this verbally, it might be a bit easier.
Okay, the issue is my internet is here, you breaking.
Okay, so maybe we can. Okay. Shuna has also sent something on the group.
Well, okay, we can go with the that with lactose if the nephrologists are starting to prescribe it for CKD, because it's been shown through studies it does reduce progression to end-stage renal disease. So yeah, perhaps, but these days it's not.
Okay, so I think we are, I don't know, I think we can move on. Spironolactone.
That's a tough one. We do a risk benefit analysis and see maybe if its benefits outweigh the risks. Because also there will be the tendency in end stage renal disease, where kidneys not they won't be able to excrete potassium as efficiently as they were, and using it might also retard its excretion. So I don't know. Maybe see if the benefits outweigh the risks.
I think yeah, to just settle it, Nugal said it best. It's a relative contraindication, meaning it can be used with caution, of course. It's a relative contraindication. I think that's it. It's not an absolute.
And even the question does not specify the failure, it's just renal failure. We don't know if it's acute or chronic, or it doesn't matter.
Yeah, sure. It doesn't specify if it's acute or chronic, so you can just.
Yeah. So I don't know. Or it's generally acute or chronic renal failure.
I think generally it's contraindicated, but then again, like I think what that whole discussion I've gotten from it is, as much as it's contraindicated, it's not absolute contraindication. You can do your own risk benefits analysis on each patient. I mean, we're always talking about individualizing care. So just do the analysis and decide for each specific case, is it going to work or not?
But the thiazides can't be used in some stages of renal failure. Like if the GFR is below 30, I think.
I think we'll settle on spironolactone. I think we can move unless anyone has any other issue. Calcium channel blockers may worsen left ventricular failure, are contraindicated in heart failure, can cause hypoglycemia, are not used in renal failure. So which one is true, I think? Yeah. Answers. I personally think may worsen left ventricular failure. Anyone with a different opinion? And we know the overdose of the CCBs can lead to hyperglycemia, not hypo. Any contributions, disputes, opinions?
Are they contraindicated in heart failure?
Yeah, they are as well. I think so. But I think it's specific to systolic dysfunction, or I'm not sure. Anyone who has a better explanation?
then that also means that B is a possible answer.
Yeah. So I don't know, we can weigh between A and B. Which one is the best answer? I'm seeing that for CCBs, specifically the non-hydro pyridines are contraindicated in heart failure. So I don't think we can generalize them. So I personally think the best answer would be A. I think Hiral is saying calcium channel blockers might be expected to have beneficial effects in systolic heart failure by reducing the peripheral vasoconstriction and thereby reducing the left ventricular afterload. Does this mean they are used for left ventricular failure? I think Thomas is saying the hydropyrimidine calcium channel blockers can be used in heart failures. So is it specific? Okay. Hiral, I think they are, but to be confirmed. We've seen that the DHP calcium channel blockers can be used for heart failure. So yeah, the best answer would be A. I think we can go into question 87. Cysts of entamoeba histolytica are best eradicated using is A, diloxamine furet, metronidazole, furet, tinidazole, nidazole.
A, diloxanide furoate.
Yeah. I've seen this something sent on the group by Gela. On the same histolytic cyst should be treated with aromycin, iodoquinol, and diloxamine furet. So choice A is our answer. On the chat I'm seeing someone asking why do we use metronidazole? Abbas thinks metronidazole is first line. I'm seeing metronidazole is the drug of choice for symptomatic invasive amoebiasis. And if you administer it, you should after administering metronidazole, you should administer paromomycin to cure any luminal infections. Shrina, are we going through the SAQs? Have we? So when you administer metronidazole, you should not co-administer metronidazole and paromomycin. Instead, you should give metronidazole first, then paromomycin. Ali saying metronidazole is more effective on trophozoites, while diloxadine is effective for cysts. So you combine both. Combination of both is preferred. Okay, thank you, Ali.
I don't have another paper. Maybe if somebody can share.
Did you go through the sample questions from the portal?
I don't think so, unless that day I wasn't available. Maybe we can download that, or I don't know, guys, maybe we can share. If you have another paper, but I know there are papers you've not gone through them. So if anyone has downloaded any of those papers, you can just share, then we continue.
I don't know if we've done this, but we'll start from the last page going on the top. Have we done the papers that are in the PPB portal? I don't know.
But I also don't think so.
Okay, so for now we can start this.
But in the meantime, we can be doing this, then we can do that.
Yeah, we can do that one later. Amma?
Yeah.
Okay. We take a 5-minute break, or we continue?
So we We can take a 5 minutes break or 4 minutes, then we start. The progress of biotechnology in developing countries is rather low for the following reasons, except okay, so which of these options would not cause low progress? Okay, I'm saying someone says C. He says there's policies sustained, government funding. Someone else, support, bring in your opinions. So there's a policy sustained government funding. So if you have policies that are sustained and there's government funding, then you would expect there would be a better growth for biotechnology. But I doubt that it's the case here, but yeah. So I think, yeah, see, there's policy sustained government funding. I also agree with that. Patience. Don't worry, we'll get there. We'll get there. We've started from the last question. Okay, so anything to add, Ama? I think we can move. Some of the commonly used naturally occurring tools in genetic engineering. Some of the commonly used naturally occurring tools in genetic engineering. Okay. Question 248, we have said C.
Okay, for 247, I think the answer would be B.
The answer would be D.
B for the enzymes, the restriction enzymes are usually tools because they're used to, like as we discussed yesterday, cut the DNA into fragments. So they're the tools.
Right, okay, some kindly repeat what you've said.
Okay, for 247, B, the restriction enzymes are actually classified as tools, and that is because they're used for cutting, like they're basically used to perform a certain function. Okay, vectors, I feel like they're also under that, but I'd actually go with the restriction enzymes, or the enzymes, basically. Okay, I was saying B for the enzymes. They're actually classified as tools. The restriction enzymes, to be specific, and the other enzymes, the ligases, because we basically use them for different purposes during that. So, and they basically make work easier in that case. So they're usually classified actually as tools in genetic engineering.
Okay, so what other tools are there some for genetic engineering?
I think the vectors are also tools. I don't know, but you could confirm. You could confirm it.
What's the answer for 246, please? I was kicked out. The basic tools are enzymes, vectors, and host organs, organisms.
So all these options are tools for genetic engineering.
So is it okay if we say the
Lydia, you're breaking. You've not had your question. Okay, if we get Lydia back, maybe she'll ask her question, but Hiral has also sent something in the group on the tools for genetic engineering.
number 247?
Pablo, vectors are not only naturally occurring. I thought they were. Maybe you can give us an example of a vector that is not naturally occurring. Lydia, bado ulimute kama before you finished your question, whatever you're saying. So
I was saying only number 247, can we say vectors because they have just said enzymes and not specified which enzymes we use in genetic engineering, and we know it's restriction enzymes. So can we take vectors as our right choice?
honestly, I am not so sure what I would say is the most accurate answer. So I don't know.
I agree, because it can also be like ligase enzymes or any other enzymes. So vectors, enzyme is just a common word, but for genetic engineering, the specific one is restriction enzyme. So vectors is the right answer from the picture that Hirola sent.
Okay, before we settle on vectors, I'm actually finding some information that where they're actually saying some major types of okay, I'll just say it in the group. So there are 4 major types of vectors: the plasmids, viral vectors, cosmids, and artificial chromosomes. So common to all engineered vectors are an origin of replication, multi-cloning sites, etc. So they're saying they're usually genetically engineered. So doesn't that mean that they're synthetic? Because they're usually genetically modified. They're not used in their natural form.
And I'm also getting that from another site as well. Okay, let me just share it. Alafu you guys can decide.
They are genetically modified by the bacteria, not by engineering.
Okay, guys, so what are we agreeing on here?
Maybe you can just put a star and then proceed to the next question, because at the end of the day, they won't repeat the question. So I think we are safe.
Excuse me, what is the answer for the previous question, please?
For which question? Just mention the number.
246.
That's our next question. So 246, which of the following statements is not true about genetic engineering? So which of those options is not true about genetic engineering? And Gaius is there using the one phrase he has recently learned. So which of the following statements is not true about genetic engineering? Okay, Hirao says, hey, it only involves genetic material transfer of related species. Yeah, I don't think the species have to be related, especially even when you consider our best example, insulin and everything. The species involved are not related or something, but yeah. So then which of the following bacteria is used in transferring genetic information in plants?
We said A yesterday.
Okay, then okay, then I guess then we can just continue. The following are products of evolutionary technology, except which one? Yeah, I think humulin is a type of insulin. Or the, what is it, intermediate acting.
Yes.
Yeah, so, well, so which of these products, the following are products of evolutionary technology, except which one? Okay, Rami says C, traditional medicines. Okay, Lydia also says C. Early you were saying B. Kindly, if you have maybe an explanation or something why you think it's B. Because even me, I was thinking it's C, but okay, someone says in traditional medicine, no technology is involved. Okay. Gary, you're saying humulin is a product of recombinant DNA technology. So then doesn't that mean you actually saying that is has used evolutionary technology? I don't know. I'm not getting your answer and your explanation. Maybe you can just, if you're in a position to unmute, maybe I or we can better understand what you're saying.
I think personally, I think the best answer for that is D, the soaps, because basically soaps don't use any. Okay, they're not really biotech products, and okay, for example, okay, just by elimination method, bread is actually made using yeast, and we actually use the process of fermentation too. When we're creating or when we're making bread rather. For humulin, it's actually a biotech product, and organisms, microorganisms are actually used for that. In that case, that is in the synthetic synthesis of through genetic engineering. And traditional medicines, I think some of them relied on fermentation, if I'm not wrong. But soaps are very unique. They're basically modern.
I have something to say. The question, it has just said technology, not biotechnology. So I guess soap
But
that
it's evolutionary.
Yeah, it's produced nearby a chemical process in the industry. I don't think it was there before. It has evolved over time for us to produce soap.
Let me
But
put it in another way.
traditional medicine, you just go harvest and use them the way they are. The only thing maybe you need to crush them so that you mix with water. Nothing more with technology has been used in tradition.
Okay, I'll put it in other words then. Okay, so evolutionary technology, then we can take it to mean basically we're using a trait from evolution, yeah, to make something, right? And bread, like I said, we use yeast. Like yeast are capable of conducting fermentation, and that is an evolutionary process because they basically gain that trait through evolution, and we employ that to make the bread. That trait that they have, or which they acquired through evolution. It's the same thing with humulin. And for traditional medicines, I think some of them actually relied on fermentation, as I said. But soaps, like if you look at soaps, like we're basically just mixing fats and sodium hydroxide to.
Can you give an example of the drug that relies on fermentation to traditional medicine that relies on fermentation?
More sick.
They didn't even know it's fermentation at the time, so yeah.
an example, wine. Wine is actually considered to be medicine. It's even in the Bible, and that is from a very long time
Oh,
ago.
don't use those examples.
Huh?
But you can move on to the next question.
Yeah, I think we can move on to the next question. Shrina says, mark that question. Then you can maybe do your own research.
But
Figure out.
also online, I was seeing evolutionary technology can also be used to imply technology that has evolved over time. So as someone was saying, like humilin in itself is a technology which has recently been introduced and hasn't evolved over time. So, and then you see like these answers that we have, all of them have a star on the answer of the question based on whoever made the paper. So I think when the person put B, they were implying that humilin in itself hasn't evolved over time, unlike the other like traditional medicines. They've evolved, soaps and then bread. So maybe that's one way to look at it.
Okay. Oh, okay. Sawa. Then, okay. The next question. So a baby requires 50 milligrams dose of a syrup solution of 125 milligrams per 5 ml. How many mls should you dispense? So the baby only needs 50 milligrams and you have 125 milligrams in every 5 ml. So 50 milligrams is in how many ml? Okay, so 50 milligrams will be in 2 ml. Then how many ml of 25% solution can be prepared from 750 ml of a 65% solution? So 65%, that means in every 100 ml, we have 65. Yeah. Oh, and then also, let me just give a disclaimer before I continue. If you have a formula that can make these calculations maybe simpler, easier, faster, this is the time, tafadhali. Anyway, okay, sawa. So 750, okay, how many ml of 25% solution can be prepared from 750 ml over 65% solution? So I think we can, this 65% times 750 is supposed to be
60 times 750 over 25. We use the formula C1 V1 is equal to C2 V2.
Yeah, so for such calculations, and I don't know, when you're comparing volume and concentration, you increase the volume, the concentration decreases. So you can, you can relate C1 V1. But then for parameters that are directly proportional, then you would have the other way, like C1 over V1, you get C2 over, okay. Yeah, so if they're inversely proportional, like you increase one, you decrease the other, then you equate them by just multiplying C1 V1 is equals to C2. Yeah. Okay. Then the next question. 40 milligrams of a medication is to be divided into 500 doses. What is the strength of each dose in milligrams? So you can you convert the 40 grams into milligrams, then you divide by 500 to get the strength of each individual dose in milligrams.
Then you get 80. 4,000 over 500, you get 80.
So you get 80 milligrams. That's the strength of each individual dose. I'm just gonna scroll up. Okay. Oh, Rami says we explain that calculation. Rami, the one for 241. So 40 milligrams of a medication is to be divided into 500 doses. What is the strength of each dose in milligrams? So 40 milligrams, you divide that by 500 doses to get the strength of a single dose. But then the answer would be in grams. So they have said in milligrams, then you can just convert it to milligrams. Hope that's okay. Then the next question. How many tablets of medicine X? How many tablets of medicine X tablets, 250 milligrams, should be dispensed to fill the following prescription? So you're supposed to take 2 grams start, then 500 milligrams QID for 6 days. So initially you take 2 grams start. So 2 grams start and a tablet is 250 milligrams. So how many tablets will you need? Will you take start? So 2 grams change into milligrams, 8. So start, you take 8 tablets, then 500 milligrams QID for 6 days. So 500 milligrams, that's 2 tablets. So you take 2 tablets QID, it's 4 times a day. So you take 2 tablets 4 times a day for 6 days. That will be how many, guys? 48. Then you add the 8 here, start. Total 56. Okay, Ali also says you do that, you get 56. Okay. And then the next question. If an injectable medicine is labeled 500 micrograms per 2 ml and a dose of 0.75 milligrams is required, how many mLs should be used? So again, we have different units again, 500 micrograms and we have 0.75 milligrams. So we have to convert one to the other. So let's say we convert the 500 micrograms into milligrams. Then that is in 2 ml. Yes.
0.5.
You get 0.5 milligrams. So 0.5 milligrams is in 2 ml. 0.75 milligrams will be in how many mLs? It will be in 3 mLs. Then we repeat the previous question. So the previous question, it just needs us to first interpret that prescription. We're supposed to give 2 grams start, then 500 milligrams QID for 6 days. And the strength of the tablet is 250 milligrams. So for the start dose, which is 2 grams, how many to 50 milligrams tablets do you need to give for you to have given 2 grams? So we got 2 grams is similar to 8 250 milligrams tablets. That was the first part of the prescription. Then for the second part, you're supposed to give 500 milligrams 4 times a day for 6 days. So 500 milligrams is 2 tablets. So you give 2 tablets 4 times a day for 6 days. Then that would be, yeah, so 48 plus 8. Okay. Okay. I think we're done with the calculations. We can Trina, we can continue. Okay, so the next question, an ingredient added to tablet formulation to improve flow properties of granules in a compression dye is known as a what? So, we've done excipients quite a number of times. So what is it that improves flow properties? Glidance. Helen has said we also need to remember that lubricants will, what is it called? Prevent friction. Then what else? Oh, then Shuna is asking, what about emollients? I don't know, someone tell us about emollients. I don't know, I thought it's a formulation on its own. What are emollients?
I think emollients are usually used for preventing moisture loss, especially in lotions where you don't want using them for dry skin to prevent loss of moisture from the skin.
So moisturizers are emollients. I'm a
I think they
moisturizer have emollients.
I think they are added to topicals to give the cooling sensation. Like the I think so.
And then plastics. Okay, ask about examples of each moisturizers. Something like for emollient, something like zinc. So zinc oxide. I think zinc oxide is an emollient. Give us examples of yeah, I'm also seeing lanolin is also an emollient. So glycerin is also an emollient. Okay. Okay. Cocoa butter. Okay. Okay. I think we can continue. So plastics are normally sterilized by which method is used to sterilize plastics? I'm being told ethylene dioxide. Yeah, ethylene dioxide because it's at least good for what are they called? Thermolabile heats. It's it's a gas that is used to sterilize plastics and other medical devices that are heat sensitive.
Also radiation and steam autoclave.
Steam autoclave can also be used for plastics.
Yes. Basically, there are three methods of sterilizing plastics. The one has just been stated, and gamma radiations and steam autoclave.
Okay. Okay, so guys, what do you think Basi is the, I don't know. Rami is asking, so which makes B also correct?
No, I don't think so.
Okay, Saru, endelea.
Yeah, I know what amesoma about the plastics, but I really feel like they would melt.
It is just from
I
Google
think
anyway.
also for most of these questions, we are seeing it's like all the choices can be applicable, but then we just have to come up with a system that help us to find the most appropriate choice. As much as all of them can be, then we have to find the most appropriate.
Okay, B is not, but it is, well, unless you are talking about dry heat, it's not steam.
My answer is D.
Yeah, D is okay. We go on, please.
Okay, so then mannitol may be included in pharmaceutical preparations as a what? As a bulking agent. I think in the group there's quite a few things about those, yeah. So maybe we can just again go back and check if you need to. The process of grinding a substance to a very fine powder is termed as okay. Rami says trituration. Then what's the difference between trituration and levitation?
I think trituration is not for a powder. It is for semi-solids.
Which one is for semi-solids?
Titration.
What about levitation?
Insoluble substances to a fine powder. So I think it is levitation.
Yeah. Remy says levitation is used for wet. I don't know if to call them wet mixtures or wet powders.
But
Then
I remember when we were making semi-solids, we titrate until they produce the clicking sound using the mortar and pestle. Oh, levitation is also wet. While wet, sorry.
so okay, guys think there's one where water is being added and the other no solvent. The one that is adding water is levitation. Yeah, so I still think think the answer is still trituration, where you make the fine powders, the very fine powders. In navigation, you mix with water to make the very fine powders, and yeah. So I think we can continue. One teaspoonful of substance X solution, which is 30 milligrams per ml, is diluted up to 480 ml mark of water. What is the final concentration of the solution? So if 30 milligrams is in 1 ml, 480 ml. So it's you get the 30 ml. The 30 milligrams has been diluted to make 480. So the 30 milligrams is currently in 480 ml. So in 1 ml, we're going to have how much of it? Oh, wait. Okay, let's. Yeah, one teaspoonful of substance X solution is diluted. So 1 teaspoonful has how many ml? I think that's also something we have to consider. So 1 teaspoonful is what, 5 ml. So so you have 5 ml of that 30 milligrams per every ml. So that's basically 150 milligrams dissolved in 150 in 480 ml, guys. Okay, someone help me type what I'm saying, because I'm getting confused now. 1 teaspoon is 5 ml. So the 5 ml, you multiply it with the 30 milligrams, so that our substance X, we have 150 milligrams of it. Then now, the 150 milligrams is what we are diluting for 80 ml. Yeah. So basically we have, yeah. So I'm saying Glenn has done the calculation. She said it's 0.31 milligrams per ml. Then the next question, if 60 grams of if 60 grams of 1% hydrocortisone is mixed with 80 grams of 2.5% hydrocortisone, what is the percentage weight by weight of hydrocortisone in the final mixture? So 60 grams of 1% is mixed with 80 grams of 2.5% hydrocortisone. What is the? Okay, again, kama mtu ako na formula that makes these things easier, the better. Personally, I figure those things as I move. So the 60 grams of 1%. So 1% means 1 gram in 100 grams. So per 60, so if we have Yeah, 1 gram in 100 grams. So in 60 grams, we'll have 60 of that. Then yeah, so 1 gram is 100. Then in 60 grams, we'll have 0.6 grams. Then 80 grams of 2.5%. Again, 2.5% is in 100. In 80 grams of that powder, how many grams do we have? Then you add the grams of hydrocortisone in each. Alafu whatever weight of hydrocortisone you get is now the weight of hydrocortisone in 60 and 80 in 140 grams of drug. So what is now the percentage? Wherever. So we've said 60 grams is in 60 grams of 1%, you'll have 0.6 grams. Then 80 grams of 2.5%, here you'll have 2 grams hydrocortisone. So the 2 grams and the 0.6 grams, that is 2.6 grams, is in 140 grams. But then for percentage weight, it's weight, actually here it's weight by weight, it's weight in grams in 100 grams of the whole thingy. So 2.6 is in 140 grams. What about in 100? Someone said you get 1.85%. Okay, also, B has said you can just simplify the calculation and do for the what we have, C1, V1, then you add to this other one, you get, we don't have C, which is what we are looking for. Our V, which here instead of volume, we have the weight, will be 140. Then that actually simplifies it much easier. Yeah. The next question. Aluminium, whose oxide is that, has a gram atomic weight of 27. What is the milli equivalent weight? So the milliequivalent weight is the atomic weight you divide by the valence of your element or whatever compound you have. So it is the atomic weight you divide by the valence of aluminium. Rami says you get 9. Okay. Yeah. So you get 9. I think we can continue. How much lidocaine is present in 30 ml of 1 in 1,000 lidocaine solution? So in that ratio 1 in 1,000, it means it's either 1, it can be either, I don't know, weight by weight by volume, I don't know, whatever, but it's okay. But considering we have how many ml of how much lidocaine is present in 30 ml of that, so it's a solution, so it's volume. So the 1,000 is ml, and then so it's 1 gram of lidocaine is in 1,000 ml. 1 gram is in 1,000 ml. So in 30 ml, how many grams do we have? Yeah. Because weight, yeah, for weight by volume, it's grams in ml. So if the answer you get is in grams, then you convert to.
Okay, just how do you
Yeah.
know that it's of lidocaine and not 1 milligram of lidocaine?
How do we know it's not?
How do you know it's 1 gram and not 1 milligram of lidocaine?
The units are normally for, even when you're doing percentage concentration, it's either grams in 100 ml or ml in 100 ml. The units are normally grams.
Okay, thank you.
Even for the ratio, I think it doesn't really matter provided when you're saying ratios, provided they correspond. So mgs should correspond with mls, and I think grams should correspond with liters. So yeah, it doesn't for this question, I don't think it really matters, because even if you took 1 gram is in 1,000 liters or 1 mg is in 1,000 ml, I think you'd still get the same answer, provided your measurements are correlating.
Shrina, we can't see your screen. Or is it just me? Okay, Lynn tells me akona kitu ya kuongeza. Please go on. Okay, so yeah, so we were doing question 31. So we said 1 gram in 1,000 ml. What about in 30 ml? Then you get grams and
1 milligram.
jioni kama kuna what we're getting in grams, so you convert now to whatever unit.
It's 1 gram.
Yes.
Come on. Okay.
Vile sijakusikia.
Ati? Oh, I'm saying, can you hear me?
Yeah.
Oh yeah, I was saying the ratios, they should
Okay. Is there someone who has a question or something to add ama tuendelee? Because I've lost Willie, I'm not sure what he was saying. I think we can continue, basi. Okay, so okay. Then
We finish this last question and then continue from here.
Okay. So the recommended adult dose for medicine is 10 milligrams per kg per day. For an adult weighing 50 kilograms, how many milligrams of the medicine is required every 4 hours? So per day, we're giving 50 milligrams per kg per day. Our patient here weighs 50 kilograms. So we do 50 times 10 to figure out how much drug we need to give in a day. Then that dose is divided every 4 hours. So the patient is taking the drug 6 times a day. Yeah, so you divide that by 6. Question says if you do that, you get 83.33. Okay, so I think we can stop there for now. Then we'll continue. We'll see each other at 4 p.m.
Shina, kindly share the other paper that we completed in the morning.